In this video, we'll be discussing high-frequency oscillatory ventilation for the NICU setting. Our objectives is to define high-frequency oscillatory ventilation and its clinical significance in the NICU. We'd like to explain the principles of operation, discuss indications and contraindications, as well as provide practical tips for setup, monitoring, and troubleshooting. High-frequency oscillatory ventilation, or HFOV, is an advanced mechanical ventilation technique that delivers very small tidal volumes at extremely high frequencies, typically from 3 to 15 Hertz, which equates to 180 to 900 breaths per minute. Unlike conventional ventilation, high-frequency ventilation actively manages both inspiration and expiration phases, maintaining a constant mean airway pressure to facilitate gas exchange through mechanisms such as diffusion and convection. In the NICU, high-frequency oscillatory ventilation is particularly valuable for managing severe respiratory conditions in neonates. Its clinical significance includes lung protection, management of severe respiratory distress, treatment of air leak syndromes, and improved oxygenation. Principles of high-frequency oscillatory ventilation operation include utilizing a continuous descending pressure, known as mean airway pressure, to recruit and maintain alveolar expansion, thereby improving oxygenation and preventing atelectasis. The map is set above that used in conventional ventilation to achieve optimal lung volume. Unlike conventional ventilation, high-frequency ventilation actively controls both inspiration and expiration. A piston or diaphragm generates oscillatory pressure waves that facilitate gas movement into and out of the lungs, enhancing carbon dioxide elimination. Some of the parameters that will be controlled when set up include mean airway pressure. This is used to keep the lung at optimal lung volume. Its main effect will be oxygenation. However, if it's too low, it can lead to low lung volumes or atelectasis. Or if it's too high, it can lead to high lung volumes, also known as overdistension. PaCO2 will be adversely affected during these cases. When appropriate adjustments are made, PaCO2 will improve. Next is amplitude or power. This is the pressure difference generated by the oscillatory mechanism, which primarily influences carbon dioxide removal. Adjusting the amplitude alters the tidal volume delivered by the ventilator. Frequency is the rate of oscillations per second. Lower frequencies result in larger tidal volumes and enhance carbon dioxide clearance, while higher frequencies produce smaller volumes and can reduce carbon dioxide clearance. This is because our total cycle time will be affected by frequency. Lower frequencies will increase our total cycle time, allowing for longer exhalation periods. Inspiratory time is set on a percentage. It is the proportion of oscillatory cycles dictated to inspiration, typically set between 30 and 50%. Here at P-South, we use 33%. And last is bias flows. This is a continuous flow of humidified gas through the circuit, aiding in maintaining a desired map and facilitating gas exchange. This slide will cover quite a lot of physics. High-frequency oscillatory ventilation enhances gas exchange through several mechanisms beyond the bulk flow, which include the Taylor dispersion. This is an augmented mixing of gases due to oscillatory flow pattern. The pendulum effect, which is a distribution of gases between lung region with different time constants. Asymmetric velocity profile is a variation in flow velocities that promote gas mixing at the alveolar level. And then molecular diffusion is the movement of gas molecules along concentration gradients. By employing small tidal volumes and maintaining a constant lung inflation, High-frequency oscillatory ventilation also reduces the risk of volume trauma and barotrauma, common complications associated with conventional mechanical ventilation. High-frequency oscillatory ventilation is employed in neonate intensive care units for specific clinical scenarios where conventional mechanical ventilation may be insufficient. The primary indications for high-frequency ventilation in neonates includes respiratory distress syndrome, particularly in preterm infants. High-frequency ventilation can be utilized to manage severe RDS, aiming to improve oxygenation and reduce ventilator-induced lung injury. When conventional ventilation fails to maintain adequate oxygenation, high-frequency oscillatory ventilation serves as a rescue therapy to enhance gas exchange. Conditions such as pulmonary interstitial emphysema and pneumothoraxes may benefit from high-frequency ventilation due to its ability to provide effective ventilation at lower airway pressures, potentially reducing further air leak progression. High-frequency ventilation can be considered in severe cases of meconium aspiration syndrome to improve oxygenation and facilitate the clearance of meconium from the lungs. And last, high-frequency oscillation ventilation can be utilized as part of the management strategy of persistent pulmonary hypertension of the newborn to improve oxygenation and reduce pulmonary vascular resistance. High-frequency ventilation is not typically a first-line therapy in the treatment of respiratory failure. It's initiated upon failure of conventional ventilation. Ventilation failures categorized as a plateau pressures of greater than 30 to 35 centimeters of water with an expiratory tidal volumes of 5 to 7 mils per kilogram and severe respiratory acidosis, which means pH is less than 7.1. In children and adults, any condition with oxygen failure, for example ARDS, is defined as an SpO2 of less than 90% and a PF ratio of less than 150, despite FiO2 being 60% and optimal PEEP or oxygen index of greater than 50. To calculate our oxygen index, we will take our MAP multiplied by our FiO2 multiplied by 100. All of this will be then divided by our PaO2 measured in kPa times 7.5. There are no absolute contraindications to high-frequency oscillatory ventilation. However, there are some relative contraindications, which include obstructive airway disease. It's a condition characterized by increased airway resistance, such as severe bronchomalacia, which may reduce the effectiveness of high-frequency ventilation due to potential air trapping and hyperinflation. This can increase the risk of pulmonary barotrauma, including pneumothorax and pulmonary interstitial emphysema. Hemodynamic instability in neonates with significant cardiovascular compromise may experience exacerbated instability during high-frequency ventilation. The continuous distending pressure used in this ventilation mode can impede venous return, leading to decreased cardiac output. Also, the continuing distending pressure in this ventilation can potentially impact intracranial pressure and cerebral perfusion pressure, which are critical in managing traumatic brain injury. When initiating high-frequency ventilation in neonates, the following precautions are advised. Due to the risk of barotrauma, vigilant monitoring of signs of air leak syndrome, such as pneumothorax, is essential. Regular clinical assessment and imaging studying should be performed as indicated. High-frequency ventilation can lead to abdominal distension, which may compromise ventilation and perfusion. Monitoring abdominal girth and implementing measures to reduce distension, such as gastric decompression, are recommended. Increased airway secretions can occur during ventilation, potentially leading to airway obstruction. Regular suctioning and ensuring adequate humidification of inspired gases are important to maintain airway patency. The patient should be also hemodynamically stable. If not, consider optimization of hemodynamic status prior to initiation. Here at Peace Health, we use the Sensor Medic 3100A high frequency oscillatory ventilator in the NICU. There are two models, an A model and a B model, primarily in use. The A model is typically used for patients under 30 kilograms, whereas the B model is used in patients over 20 kilograms. You can think of high frequency oscillatory ventilation like a vibrating CPAP machine. The device delivers a constant flow of heated humidified gas, providing a set flow rate, also known as bias flow. This flow produces a constant mean airway pressure like that of CPAP. An oscillating piston pump, a bit like a woofer of a loudspeaker, then vibrates the pressurized gas at a set frequency. This next slide is quite populated, so we'll only go over a few things, but I recommend you refer to the education guide for more detailed information. When setting up high frequency oscillatory ventilation, we will set up only a few parameters, and most of those parameters will be fixed. First will be mean airway pressure. This is typically set 3 to 4 centimeters above MAP on conventional mechanical ventilation in neonates. Our amplitude or power is adjusted until there is a perceptible chest wall motion from the nipple line to the umbilicus, also known as chest wiggle factor. It can be set based on the patient's weight, and in most cases, it just follows physician's orders. We'll most likely never adjust a bias flow, frequency, or I time once initially set. Typically, on initiation, bias flow is set 15 to 25 liters a minute for patients under 1 year of age. Frequency is typically set between 12 and 15 hertz, and I time, as mentioned earlier, is set to 33%, and that's due to because higher I times may lead to air trapping. FiO2 would target a SpO2 of 88 to 92 or physician order, and we'll set our high and low pressure alarms plus or minus 2 centimeters of water of MAP. Oxygenation is dependent on MAP and FiO2. MAP provides a constant descending pressure equivalent to CPAP. This inflates the lung to a constant and optimal lung volume, maximizing the area for gas exchange and preventing alveolar collapse in the expiratory phase. In high-frequency oscillatory ventilation, oxygen can be separated from ventilation as they are not as dependent on each other as in conventional ventilation. Ventilation or CO2 elimination is dependent on the amplitude and, to a lesser degree, frequency. Typically, when we're making adjustments to our device, we will be making it based on oxygenation or ventilation. In this example, if we have poor oxygenation, we can either increase FiO2 or increase our MAP 1 to 2 centimeters of water. On the other end, if we have poor ventilation, we can decrease amplitude. Other option is actually to increase frequency 1 or 2 hertz if we've already reduced our amplitude to our minimal level. Patient assessment should be done routinely, and it typically includes the following. ABGs should be performed 30 minutes post initiation of ventilation. ABGs should also be frequently based on clinical status. A gas should also be drawn 1 hour after any major setting changes or clinically indicated. Chest x-ray should be performed within the first 4 hours of initiation of ventilation or when clinically indicated. We also might want to think of a chest x-ray whenever lung overinflation or underinflation is suspected. In the next slide, we will discuss chest wiggle factor. And we will watch a video on patient assessment. Along with the next video, we will want to monitor heart and GI sounds, which can be unreliable or difficult to assess while the ventilator is on. In order to assess the heart and the GI sounds, we need to stop the piston temporarily. During this time, lungs will be remain inflated, so we don't have to worry about de-recruitment. If available, we also want to monitor transcutaneous PO2 and PCO2. As mentioned earlier, high frequency oscillatory initiation often reduces venous return and blood pressure, so we might think about giving 5 to 10 mils per kilogram saline bolus. Here, we can see a good representation of continuous and equal vibration in the chest from the nipple line to the umbilicus in the neonate. This is what we would consider chest wiggle factor. In this video, we will see a patient assessment. As mentioned, we want to assess vitals continuously. We want to check capillary refill, skin color. We want to monitor temperature, blood pressure, and oxygen saturation. Continuously monitor and assess the depth of chest wiggle factor. A decrease in wiggle may suggest tube blockage or worsening compliance. An increase in wiggle at the same amplitude suggests an improvement in the compliance of the lung. A presence of asymmetrical wiggle as compared with both sides of the chest may indicate a pneumothorax or tube blockage. And then vibration mainly in the neck could indicate a dislodged ET tube. We want to auscultate, though normal breath sounds cannot be heard. They are mainly a friction sound. However, you may denote changes in the intensity of the piston sound or may become reduced in an affected side when the ET tube is too low and is ventilating only one lung, or when a pneumothorax is present. Weaning from high-frequency oscillatory ventilation is not based on fixed protocol, and various methods are followed. The process involves weaning to an extent where the patient can tolerate conventional ventilation. The parameters that determine weaning readiness are FiO2 and mean airway pressure. Once oxygenation goals are met, 2 steps can be followed. The first step is to wean FiO2 to less than 40%, considering a saturation of more than 88%. And the next step is to decrease MAP in increments of 1 to 2 centimeters of water to achieve a mean arterial pressure of around 15 centimeters of water. After achieving the above, the next approach is to transition the patient to conventional lung protective ventilation and target saturation of more than 88% with a mean airway pressure of 20 to 25 centimeters of water for the next 24 hours. Failure to wean is considered when the patient is weaned to conventional low tidal ventilation and fails to maintain a saturation of 88 and above in the initial 48 hours. Before we wean, we may be doing a lot of titrating. Here is a detailed reference guide on what setting changes we would need to perform based on our blood gases. And we could take one example. Let's say we have our patient on an FiO2 of above 60. If we get a blood gas and it shows that we have a low CO2 with a low oxygen, the changes that we would need to make would be to increase the airway pressure or the FiO2, as well as decrease the power or amplitude. Another example, if we are already delivering an FiO2 of below 60 and we have a high CO2 with an acceptable O2, the only change that we would have to make on our device would be to increase our power or amplitude to get an acceptable PaCO2. This reference guide can be found in your education guide and resource material, and I highly recommend you to review it or have it available near your patients for easy reference to make ventilation changes. Next, we'll go over some troubleshooting of clinical issues. These clinical troubleshooting guidelines are to help orient you to a possible cause for a clinical change. These only address common problems and are by no means all-inclusive. So let's start about the first problem. The patient experiences an abrupt deterioration with a rapid rise in PaCO2 while being ventilated on high-frequency oscillatory ventilation. There may or may not be amplitude changes. So, what can be our problem? What can be causing this problem? We can consider the following: an acute airway obstruction, for example, a mucus plug. We could have a bronchospasm. We could have a pneumothorax, or a main stem intubation or extubation. How are we going to rectify this? Well, we can assess airway function or patency. So we can check our suction our ET tube. We can auscultate. We can check our transcutaneous PCO2, and we can look for diminished chest wiggle. We can also recommend a bronchoscopy. We can draw an ABG if the acute decompensation results in profound hypoxemia, so an SpO2 of less than 80%, or acute hypotension. We definitely want to notify our physician of these developments immediately and possibly recommend a chest X-ray. During this time, we might consider removing the patient from the oscillator and begin manually ventilating. Our next scenario is a patient experiencing an abrupt deterioration with a drop in oxygen saturation. Some of the problems may include, again, airway patency, so a mucus plug. We might have some changes in our mean arterial pressure. Patient may have become disconnected from the device and have a loss of lung volume, or a possible pneumothorax. Correcting these might include considering a fluid bolus or pharmacological support to maintain an adequate mean arterial pressure. We may need to recheck the X-ray and assess or rule out the presence of a pneumo. Our next issue is hypotension. So increased intrathoracic pressure from an elevated mean airway pressure may cause decreased blood flow, resulting in reduced right ventricular preload. So we might consider giving a fluid bolus. We might consider pharmacological support, or even just reducing our pressure. Last is an elevated CO2 refractory to increases in amplitude. Well, our mean airway pressure or lung volume may be too low. As a rule, when the set amplitude is approaching 3 times the set mean airway pressure, the common reason is that lung volumes are too low, resulting in poor gas exchange. So to correct this, we might want to increase our mean airway pressure. We also may want to reassess for lung volumes and get an X-ray. Thank you for completing this presentation. Please review the presentation notes and education guide for more details. If you have any questions, please regarding high-frequency oscillatory ventilation, please ask your clinical educator. And if you'd like more personalized education on the device, on setup and initiation, reach out to your clinical educator. I hope it was as informative to you as it was to me. Thank you.